Good morning, ladies and gentlemen. Thank you for this opportunity, Dr. Vignesh. And we have heard so many difficult situations, and we move on to the one of the most difficult complications, managing posterior capsule rupture. No financial interest in this. What financial interest can we have in posterior capsule rupture? But then still, PC rupture, when can it happen? It can happen at any time. Not at any time, but from hydro procedure. We saw some of the videos where we saw a pupil snap, and during nucleus management, nuclear INA and IOL implantation. And sometimes even after IOL implantation, when you have a weak posterior capsule in posterior polar cataract. So this is, just see this case. This is one case where this rexus is intact. But keep watching this area. There's a white plaque there. So I just ignored that. And while I was trying to chop, I see one flap here. Can you see this flap? I'm just touching it with my chopper there. So that's a free flap. A free flap cannot be cortex. So now we should know that there is a PC rent. I have now split it into two pieces. One, and now putting viscoat into the AVF, just under the nucleus. And if you split it into two pieces, disadvantage is it can drop more easily. A single one may not drop that easily. But then while taking out, I have extended the incision, clear corneal incision, not a very great idea. But different options are being shown. You can always suture this incision. And then piece by piece, you can take it out with the Sinski, with a large forceps, with Vectis. Or if you think that it is dipping down, you can put a sheets glide and then prevent these pieces from falling, because smaller chips which we would have chopped epinucleus or nucleus bits may drop. We may not know that they are under the iris, and slowly they may drop off. So these things, the sheets glide can help in these situations. And once the nucleus is completely taken out, then see, one more piece was there, and that is prevented from dropping by. Then suture, the main incision, is very important. There should not be leak while doing a vitrectomy. So anterior vitrectomy, without anterior vitrectomy support, it is not wise to do a phaco. So keep your irrigation away from the PC rent. It should aim at the iris plane, above the iris plane. And vitrectomy assisted with triamcinolone is very useful, but then later on we will know. Once vitreous is gone, we will know after a few years of experience. And the 3-piece IOL goes into the sulcus, and the sutures are completed. If you want more sutures, please suture, because endophthalmitis, AC leaky, AC shallow, these are all very bad complications which you can have after a PC rupture. So later on, it should look like an uncomplicated case. That is the point. So here, this is the stage when most of us sometimes get PC rupture. So here, that means the last nucleus piece. That is where the bag is almost empty, and you can get surge, and your PC can come and touch your phaco probe. If you have noticed, though, Dr. Sunil showing very hard cataracts, he never had surge during the whole procedure. Whatever machine you use, he was not using a very high-end machine. Moderate machines, any machine can do any cataract, provided you keep the settings appropriate and don't have surge. So if you see somebody keeping 500, 600 vacuum, don't go back and try to do just with 500 or something magic will work. Nothing like that will happen. You'll get surge, that's all. So depending on the tip which you are using, the size of the tip and the tubings and the quality of your machine, you can keep power and the vacuum accordingly, so that you don't get surge and you get adequate power to cut the nucleus. So here I'm not taking out my irrigation or my phaco probe. Second instrument is withdrawn. Always have sodium hyaluronate or viscoat. Here I will have viscoat, because that is dispersive viscoelastic. It will go into the anterior chamber and at the level of the PC rent, and it will plug that area if you have not had a vitreous loss as of now. So dispersive will plug. Cohesive will stay there, but if you start aspirating, it will come off very fast. Dispersive will not. No financial interest in viscoat, but viscoat works very well. Orocoat Plus is also there from Indian companies, and they are all good enough. And then the closing, and the chamber should not be leaky, and it should be a bimanual vitrectomy. So you will see some peaking. If you see there, that rent area, the margin might peak. If it peaks, it means there is vitreous there. And the sweeping and tugging is not a great idea. Please go to that area, cut it with vitrector, and then once it is done, look for cortex. If it is very minimal, Don't go in with irrigation again and you can cause more turbulence and you can pull out more vitreous. So this is called dry aspiration. You can go in and touch the cortex and with a small cannula and take out. Here, now you can see that vitrector is being used for this. The advantage is there are three, it is not shown here, but there are three levels: irrigation, cutting and aspiration. That is for vitreous. Any vitreous should be cut and then aspirated. But after you finish off vitreous, there is no vitreous, then you need not change hands. You can use the same vitrector. This is a larger vitrector. If you use 23 or 25, the ports will be smaller. Larger ports, if you will need more occlusion with the cortex to generate the vacuum, and that you may find it a little difficult, and you may aspirate more from behind and from the rent area, vitreous may get aspirated. But the second level should be aspiration when you are aspirating cortex. The cutting should be third. You have to change to irrigation, aspiration and then cut. Cutting is only required if you want to cut off a little cortex after taking it to the center or if vitreous comes. But remember, the disadvantage is that once you have caught cortex and if you are aspirating and inadvertently if your foot pedal goes a little into 3, you will start cutting. Then you may cut off the anterior rhexis margin or the rest of the PC and you can cause further damage. So instead of that, you can always go in, keep the irrigation on, change the cutter and use your IA and change over to the IA mode. So when vitreous comes out, we change over to the eye irrigation cut aspiration and do more vitrectomy and aspirate. And while aspirating, don't bring it to the area of PC rupture. Bring it to the safer area where there is PC. And here I am using triamcinolone. I use it only after a preliminary vitrectomy. Initially there is no point. We know that there is vitreous and clear of vitreous. Now you can see a tag of vitreous into the section. Generally it may come into the section mostly, especially leaky sections. So dilute it 1:4 and don't inject 1 cc or 2 cc into the anterior chamber. Everything will drop into the vitreous and some bit is good, but lot of it in the vitreous will generate lot of IOP rise and you have a problem later. So segmentally, where you suspect there can be vitreous, inject there and identify. You will see white strands and it can be selectively cut later. So this is another mature cataract. See, mature cataracts should all be taken with caution because they can have open PCs, weak capsules, posterior polar cataracts hiding behind it. So here also please notice the center. When I am splitting now, please notice this central area. This is more white. It could be just cortex, but it can be a posterior polar area also. So please watch while you are doing that. I am just happily chopping and rotating and all those. I am just not bothered about what I just consider see the white one there. So I am taking one piece out and one whole half of nucleus is there behind here at subincisional. I am not looking at that. I am looking at my nucleus and emulsifying. Everything is happening well. See, now this area is coming up very prominent white area. Still I am not bothered, but now I realize that this half nucleus is almost tilting so badly that it is going underneath the iris totally. That's a half nucleus. So that cannot happen. So now some sense prevails and I stop. Take my viscoat, go underneath the nucleus, no vitreous till now. So underneath the nucleus and then fill it up and plug that area till still I cannot see anything. But then I continue phaco on a higher plane. Viscoat is there protecting endothelium. So now use a second instrument. Reduce the aspiration flow rate. That is one important thing which I would like to highlight. Aspiration flow rate, if you reduce, then you can know that here you can see now. Look at the central area here. See, this is the large PC rupture which I can identify. So if you now reduce your aspiration flow rate, you will not aspirate everything which is nearby your tip. Only what is there at the tip will be aspirated. So come down to 15, 14, 12 and do very slowly. So that and the rest of the area is completely filled up with viscoat. So that will maintain the whole thing and then when we continue, you can pick up this nucleus very gently, rotate it and pick it up from different directions. Don't try to just rotate. Sometimes it can drop into the area of PC rent if it's a large PC rupture. So positioned in a location where you can see the lens going in, this is a 3-piece IOL. Every mature cataract, I have a 3-piece IOL as backup. So without a 3-piece IOL backup, I don't do any case. So this goes into the sulcus. You can safely place into the sulcus if you are sure that you have not broken your anterior capsule. But if you are doubtful about your anterior capsule, land it in the anterior chamber above the iris. So now this goes into the anterior chamber and to make sure that this one is going into the sulcus, but the trailing one is over the iris. Now, this optic is covering the pupillary area completely. So, there is no threat of this nucleus dropping. Now, we can do phaco. So, we will think that this nucleus is so close to the endothelium, it can damage endothelium. It is not so. See, I am using a chopper which is 2 millimeters long. The chopper is 2 millimeters long and it is not touching the endothelium, means that there is more space than 2 millimeters above the lens which you have placed, IOL which you have placed. So, it is relatively very safe. Don't bother too much. But then, don't do like you are doing in the bag chopping. So, very gentle chopping, minor splits and making small pieces and then emulsifying them slowly in situ wherever it is there. Don't let the nucleus move around, and use the second instrument to support the nucleus down there. With the stem of the chopper, you can support the rest of the nucleus so that it remains right on top of the lens. And also don't let the phaco tip touch the lens. Then it can damage the IOL optic also. So like that we can finish completely, and then again fill up with viscoat, and now I put in iris hooks. This is for opening up and seeing where we have left the cortex. And at this point, even if though there is no vitreous prolapse, I will use a vitrector to cut off vitreous if it comes when I am aspirating the viscoat. There is a lot of viscoat which we have pumped into the anterior vitreous, and so much of it retaining is not a great idea, but still viscoat in the anterior vitreous will not cause, or sodium hyaluronate will not cause that much of a problem like you get in HPMC. So HPMC should be thrown out after you get a PC rupture. Don't touch HPMC, don't put in HPMC. And now if the rhexis is small enough, less than 5 millimeters, then you can have a capture, otherwise you can leave it in the anterior chamber and finish off. So this is done by my, resident. So a smaller rhexis, that is okay, but the first hydrodissection did not happen, nothing happened. Second hydrodissection, see the pupil snap there, and one more he does. So you can see that pupil snap is very obvious and the iris is prolapsing, and the chopping, it doesn't stop there. So if you are sure that there is a pupil snap, as Sunil was telling, you can convert. But there may not be a PC rupture if it is not, if it's a doubtful one. But when you are chopping and trying to rotate, if the nucleus does not rotate, see, there is no rotation, it is just moving to one side. If you tap it, it is going to the other side, no rotation. At that point, we should definitely stop and convert. So here I have been called, I expand the rhexis, I make it larger, and then try to prolapse this nucleus into the anterior chamber after expanding the pupil. If you have a smaller pupil, definitely expand. If you have a smaller rhexis, definitely extend the capsular rhexis. And now once it is brought into the anterior chamber, either you can go to a different location, and if you don't want to, or you're a little upset about the whole thing, you can extend from the sides of your clear corneal incision along into the sclera by making the peritomy, localized peritomy. You can do it without peritomy also, but it will be slightly messy. Blood can go into the vitreous, into the anterior chamber and all those. So cauterize well and make a peritomy, and you can close it off better also and extend it adequately. There is no kind of being stingy on the size of the incision now, because it is a very huge nucleus and it has to come out cleanly. Do not damage endothelium more now. So because it is connected, sometimes the whole lens may come, but it may come in bits and pieces also. But make sure all the nucleus is delivered out, and then we can proceed. So, but this step of cortex aspiration, it is very important. We all relax after a phaco. Now it's everything, what is there left? Cortex only. So this is the stage where you get maximum PC runs. So now turning, see, this is when I turn the tip sideways or even down sometimes. You can catch the PC and you can get wrinkles. At this point of time, if you stop irrigation itself, it will get free. But sometimes if it is aspirated more into the port, and if you continue aspirating, it will rupture. But if you stop at that point, there is a venting foot pedal control where you should use that, and there is a reflux. So identify which button corresponds to reflux in your machine. That is very, very important before starting. After catching the cortex, you should not ask nurse, where is reflux? Reflux is not working. Don't tell that. Check that before you start your phaco. Here again, a classical example of trying to polished the PC and getting a small PC rupture there. No, we are taking a little more time. Chief Instructor has allowed that. And so see that small opening which is starting to expand because we have taken out the irrigation and the chamber is shallowing. So that is very, very important. Once you identify, do not let the chamber shallow. Retain the irrigation. Suddenly now, see, it has become a through and through limbus to limbus one, equator to equator opening. So always fill up the anterior chamber and maintain the anterior chamber. But again, here if you notice, it's a small capsular PC tear. Can you see here? This one. And lot of air bubbles. I hate air bubbles. So I wanted to take all these air bubbles and see very clearly. And so I used my viscoelastic and then pushed more and more viscoelastic so that all this visco goes out, all this air bubble goes out, more air bubble came in. But what happened, see, the small opening became a large PC rupture. See it again, I'll show you again in slow motion. See this opening, this has become such a large opening now and it is like this. So overfilling and underfilling are not good when you have a open PC, remember that. And while injecting IOLs can also be not loaded properly, it can be shot in. And see this haptic which is turned to the opposite side. Always 3-piece lenses haptic should be facing the left. And then use your hand to rotate the optic in proper position. It should not be facing towards the right. Here again, because of the malfunction of the injector, it has been injected into the bag with force. So it can cause nodular dialysis or a PC rupture. But PC rupture is for sure. There must be a dialysis or a rupture here. So if that is there, try to rotate the lens towards 90 degree away from it and let it be there. Retract and see. But don't be too inquisitive and try to aspirate here and there and all. See now lens is all stable and very nice. I can show you that there is a very small piece in the periphery, but I go with the irrigating aspiration and keep aspirating from there. See, now I have got vitreous. See the lines here? It's vitreous. So don't manipulate too much in the area of a suspected piece and use visco and retain some. See, that is the small piece area which is there, which can be just left alone. But don't go and aspirate the small little vitreous visco which is there. Let it be there. It will get aspirated or you can treat inflammation or IOP so you can treat. But don't keep on aspirating at your piece area and cause more damage. I had to do a vitrectomy for that also. Thank you very much for the patient listening.
So thank you for that excellent